Great. So good morning, everyone, and welcome to this workshop, which is organized in the context of a Scirocco Exchange project, which is the project funded by the Health Program of the European Union. The main objective of this project is to provide capacity building support to all stakeholders and organizations who are interested to improve the implementation and scaling up of integrated care. For us, the main tool or the main facilitator of this capacity building support is this Scirocco Exchange Knowledge Management Hub, and particularly Scirocco Exchange tool as a central component of the hub. And we perceive four main functionalities for this tool, which is about assessing the maturity of the local conditions enabling integrated care. Then we see the tool as a facilitator of accessing the existing evidence on integrated care so that we don't reinvent the wheel, but use the existing knowledge, existing evidence much more efficiently. And the tool also helps us with facilitating very much tailored and personalized knowledge transfer and improvement planning activities. For the purpose of today's workshop, we would like to share with you our experience, how we've been adapting and using this tool to the different local needs, local priorities, and local context. The tool has been widely used in Europe and beyond. We currently notice over 90 individual organizations and individuals. So all this kind of like expansion and adaptation is the result of this increasing demand for such tools and frameworks. And obviously we'll hear more today about what the tool is about and particularly how we have approached this whole need for the adaptation and expansion of Scirocco Exchange tool to different areas rather than integrated care. So we will be exploring or sharing the experience of four particular areas where the tool has been locally adapted. It's demand-driven innovation, care homes and integrated care, concept of goal-oriented care, and concept of long-term care. And at the end of the workshop, we would like to also share with you a couple of thoughts on our next steps for the tool, particularly how we see the use of the tool from the point of view of sustainability and exploitation. So if we look at the agenda for today, so we will start with a bit of introduction to the tool, as I said, our approach to its expansion and adaptation, and then you will hear three different examples of this expansion. So we will be hearing from Sandra Evans about the ASL project, and then two local experiences in Catalonia and Flanders. We will then break for a short coffee break for 15 minutes. And after that, we will hear again two local examples, one from Slovenia and one from Puglia region. We will then have a dedicated session on discussion, and we will conclude the workshop with our remarks on, as I said, sustainability and exploitation of the tool. There is obviously this dedicated discussion section, but as it was mentioned in chat by my colleague Nessa, please feel free to use a chat to pose your questions, your remarks and observations as we go through the presentations. So without further ado, I would like to hand over to our first speaker, Tino Marti from ETEL, who will give you insights into our approach to expansion adaptation. Tino, over to you. I'll stop sharing.
Thank you very much, Andrea. I'm just seeing, you can see my slides now?
Not yet.
Not yet. Okay.
Yeah, it's not there.
Yeah, perfect. So good morning to everyone, and thank you, Andrea. As Andrea mentioned, there's a goal for today's session is to explore the expansion, and we wanted to do it with specific examples. So we are really looking forward to hearing from the invited presenters. But first, I would like just to give you an overview of the work that has been done so far, and especially on the expansion. We discussed about the expansion of the tool, but also the model, which is the image you see in front of you with the 12 dimensions that started in the Scirocco project back in 2016 and has been expanded in the Scirocco Exchange project as an online self-assessment tool. And the focus was to accelerate adoption and scaling up integrated care initiatives. You can see on the top of the slide the link to the tool, which is open for everyone to test and use. And so just go and register. It has it's translated in 9 different languages. So we invite you to make use of it. Just to give you the whole scope of the different adaptations and applications. This has been tested in 31 regions and organizations with more than 1,200 assessments. We have had more than 480 unique users and translated now in 10 languages. And you can see that we have gone overseas and reaching other continents like Australia or Saudi Arabia. I won't go in detail, but just to remind, the model is based on these 12 dimensions to measure the maturity of integrated care through an assessment scale composed of a Likert scale of 6 positions. And for each dimension, we have developed this assessment scale, which allows to grade for each dimension the level of maturity of an organization or the perception that different players in the field of integrated care they have. So in fact, the tool is a participatory tool that helps to learn how an integrated care system at local, regional, or national level is performing. It allows to have different views from different profiles, and this is the beauty of the tool, where you can combine the different perceptions in these spider diagrams that are automatically generated by the tool and see which are the levels of agreement or disagreement, which are the strengths and weaknesses at each domain level. So this triggers the discussion within the integrated care system to see which are the areas of improvement and which are the areas of expertise that can be transferred to other places. And we will see this today in the different country presentations. So I would like to highlight this element that this is not about benchmarking, it's about consensus building. So involving different players in the field, doctors, nurses, managers, IT specialists, help to develop this consensus building process and agree on which are the next steps, or if there is some opportunity to transfer knowledge from one side to the other. But we thought that the Scirocco model and tool, they have more possibilities than only focusing on the usual suspects of integrated care. And that's why we framed the expansion of the model and the tool through 4 driving questions. The first one is, could we address new audiences? So we discuss about integrated care, but we would like to know if there are other players that are not usually involved in assessment that could have a role. So this would be one area of expansion. The other area of expansion of the model, which is even more challenging, is if could we discuss about other topics that are not necessarily connected with integrated care, or they are slightly connected with integrated care, and would the model and the tool be useful for these cases? Another question that came out when we were discussing about expansion is sometimes the 12 domains, the 6 levels Likert scale could be not enough to capture the nuances of a specific domain. Could we drill down in one of these 12 domains and look more granularity of information? And this is what we call the drill down approach. So just get it deeper into one of the domains. And the final question, could we fully expand the tool and address new audiences, new topics, and drilling down in a specific domain? So these were the 4 areas where we were challenging actually the model and the tool. And we typified 4 types of expansion. The first one was the topic expansion, and we will see different cases today on this, starting from the open innovation of the Excel project. So we are moving from integrated care to open innovation in digital health and care, which is related to integrated care, but is is a different topic. We have also experience on user expansion. So we keep the topic on integrated care, but we involve new players. And this was the experience in Estonia involving policymakers in the development of the long-term care policy. But we have also this drill down expansion. This is one example. We want to see the role of telemedicine in improving care, and this is a drill down work through the area of digital infrastructure, and we are adapting the tool with the experience of the Momentum project that assess different areas of telemedicine implementation and scale up. And then we have the most challenging one, which is the full-blown expansion, which today in some way we will cover with one of the examples, but here is one adaptation that was done to the model and the tool, which involved to rephrase the domains. That is the one on digital neighborhood maturity model, and you can see on the bottom that the model has been changed in terms of the narrative, but it remains the 12 domains of maturity assessment. So these are the 4 avenues for expansion, which shows that the model can be perfectly adapted to many different contexts, topics, users, and even getting more detail on each of the 12 domains. Finally, and I don't want to keep this introduction long, we will see today 5 counterexamples, and you can see that open innovation, the Excel project, is one topic expansion. We will see how this has been adapted also to nursing homes in the case of Catalonia. So it's a topic expansion and in some way also related to user expansion involving new users. We have the goal-oriented care approach, which we consider in some way full-blown expansion, because we are entering into a closely related topic, but can be considered as a full-blown expansion. We will see the experience of Slovenia in long-term care, and also the perceptions of healthcare professionals in Puglia related to the COVID-19 response. So I'm really excited to listen all these presentations, and I would like to hand over to Andrea to introduce the first case. Thank you very much.
I should have unmuted myself. So thank you so much, Tino, for this introduction. And now, as you're saying, we will move on to the concrete cases. So the first one is the adaptation to the concept of open innovation. So we have Sandra Evans from the ASL project. Sandra, over to you.
All right, thank you so much. I need to unmute myself. Yeah, thank you for the invitation, Andrea and everyone else, to take part in this really exciting workshop and also present our experiences that we've had with the adaptation of the Scirocco exchange tool. My name is Sandra Evans, and I'm from the University of Tübingen in the state of Baden-Württemberg in the southern Germany. And there I'm part of the team of the Lebensphasenhaus, it's called. So it's an innovation infrastructure that tries to deal with social and technical innovation on the topic of independent living and aging in place. And as such, it's an innovation infrastructure that tries to promote, user-centered and living lab type of approaches in this. I'm also the coordinator of the Excel Interreg project that has been mentioned several times already, and it's an Interreg Europe project. And for those of you who are not familiar with Interreg Europe, I think it's valuable to mention that it's a program that's funded by the European Regional Development Fund, and it tries to enhance European cohesion through exchange of experiences and mutual learning between the regions in order to improve policy. And that's that. So with Excel, what are the challenges that we are looking at? Our focus is on health and care, and I think I think in this crowd that we are, and the participants of this workshop, we are all aware of, the challenges and the pressure that is on the healthcare sector in Europe, but only, this has been something that has already been prevalent before the pandemic, but of course it's, placed some kind of a magnifying glass on issues and shortcomings that are there. And that's one aspect, but on the other hand, of course, I think it's also important to say that, it has also provided a considerable boost to digitalization also in healthcare. So, in general, I do want to point just to the challenges, to the problems and to gaps as an innovation driver, because I think still too often there's still a technology push rather than a pull and focusing on the demand. So you really do want to make the case for a problem-oriented culture, for demand-driven and open innovation, as well as outcomes-based approaches, which help, of course, to develop sustainable and relevant solutions. And this is where open innovation, the Living Lab approach, and Accel comes in. So what is Accel? Accel stands for Accelerating SME Innovative Capacities with the Living Lab approach. And we want to sensitize all parties to the benefits of the Living Lab approach by identifying good practices in our partner regions for improving local innovation and development policies, thereby increasing innovation capacities and innovation performance, and overall, actively promoting this trans-regional collaboration and learning which is in itself also innovation capacity in the end. So to better understand how we adapted the Scirocco exchange tool to now get more to the topic, I think it's quite useful to look at the architecture of the project that we wanted to use. So I think, as with any project, you want to initially, take some kind of a landscaping or some form of inventory or self-assessment, and then with that, we wanted to match the regions, based on the strengths and weaknesses, match the regions to conduct twinning activities, exchange experiences on topics that are relevant to the respective regions, and learn from each other and identify good practices that can then be inspiring for other regions, which then would be, used as inspiration to formulate action plans to transfer some of the good practices into to different regions. So that's the overall structure and flow, let's say, of the project, our project. And so initially we thought that Scirocco tool would be wonderful in identifying the strengths and weaknesses in the regions based on which they then will be matched, right? So you see here the OSAT, the online self-assessment tool. That's the lingo for the Scirocco exchange tool in the project. And so this is how we kind of wanted to integrate this into the project activities. So here you can see the adaptation or the slight adjustment really in the dimensions. Those of you who are familiar with them say there's no real change, except that instead of the digital infrastructure, we named that innovation infrastructure, and the demand-driven innovation used to be, let's say, population approach. So it did take some work, however, as you might imagine, to reformulate the objectives, because it is a different topic. And thanks to the hard work of Andrea, who really, kneeled into this work in close cooperation with my colleague Daniel Boer, who's an expert on innovation policy, and also with our advisory partner, Lika Lab. They are a living lab in Flanders. So I think we were able to come up with and develop a functional tool for assessing the maturity of open and demand-driven innovation ecosystems in the respective regions. The scale, I think, is also, very, very similar. So after the adaptation, all of the Excel partners were able to, let's say, experience the magic of the Scirocco tool, of structured multi-stakeholder dialogue, and the experience of the consensus workshop and coming up, in the dialogue with the consensus. So all partners really came back with extremely positive feedback and finding the dialogue that they conducted extremely informative and instructive for their activities in their respective regions. And so here's the spider graph just from our own experience in our ecosystem, the spider graph of Baden-Württemberg, for instance. And I think what, we had about 10 stakeholders, which is not very much, but they did have all the different, let's say, from the quadruple helix areas covered. And I think what's striking is really, for instance, in the user empowerment section dimension, you can see that there's a similar amount of participants who found it, who rated it at a lower scale versus a similar amount of people who, it's quite contrary in a very positive or a very high part of the scale. And so how does that discrepancy come? And it was interesting then to engage in this discussion and to discuss the different perspectives and come to a consensus that, while there is some user empowerment in the region, it's not concerted yet. And with the strategic placement, let's say, for us to say, okay, no, it's still something that we want to continue to work on and to improve. This is something that we then, as a, let's say, isn't part of an ecosystem, decided together. So I think that's just a really great way to get everybody on board and on a plan how to move forward. So exactly. So that's that. And just to get back to that, initially I said, right, we wanted to initially just use the OSAT for landscaping and identifying strengths and weaknesses. But throughout the project, we really kept returning to the dimensions, which really helped quite a bit in structuring, in grouping good practices that were identified, and trying to kind of facilitate, moderate this whole project internal process, which was really, I think, very valuable. So, in addition to the self-assessment, it's really helped in different levels and dimensions with the consensus building, of course, with benchmarking, which will then, of course, help with planning, defining of missions, really, having this in an ecosystem, it's quite helpful to define the missions, the priorities and policies, strategy that you want to move forward with. It's also wonderful for evaluation if you do it, at the beginning and at the end. Have we progressed? In type of monitoring, exchange of good practices, like I said, can be really helpful in sorting also that process. And like I said, I started off with the challenges, and I think that's the one of the main values is identifying the challenges and how to resolve these challenges and drive innovation, let's say. So I think that's it. I think I've probably, hopefully, didn't go too far over my time slot, but hope if there are any questions, of course, at any point.
Perfectly on time. Thank you so much, Sandra. There is already a question for you in the chat, so you may have a look, and we'll obviously pick it up during the discussion. We will now move on to Felix Martinez from the Department of Social Rights in Catalonia.
Hello, thank you. I'm just going to share my presentation. So my presentation is about our experience in Catalonia using the Scirocco maturity model to measure the integrated care in residential care during the COVID pandemic. So this is the maturity model and some context. When the COVID pandemic broke out, it hit very hard the nursing homes in Catalonia. So you can see here in the peak of the first wave, we had 554 daily confirmed cases, 555 daily hospitalizations of people living in nursing homes, and we had almost 200 deaths of people from nursing homes in a day. So this is just so you can picture the magnitude of the tragedy in nursing homes during the first wave, and this situation brought an intensification of the collaboration between the health department and the social affairs department. Seeing that this new collaboration between departments was bringing changes in the residential care area, we thought that it was necessary to measure the situation of integrated care in this area. And the Scirocco maturity model, we thought that it was the correct tool for this. So we have a triple objective. First, to assess the maturity of integrated care in the residential care area in Catalonia. Second, to diagnose the situation and possible areas of improvement. And third, to compare different geographical areas. So we thought the Scirocco model was a good tool for this because it allowed to combine a quantitative and a qualitative analysis. First, with an individual survey, where we asked the participants about the pre-pandemic and the current situation, and this is a new thing that we brought to this. And second, with the consensus sessions, where the participants only discussed about the current situation, not the pre-pandemic situation, and we kept for the qualitative analysis all the information about the arguments given on the debate. It was between April and June 2021, and more than 190 professionals with different profiles and areas of responsibility participated, and they were distributed in 18 territorial teams. Related to the adaptations made in the survey, I have to say that the Scirocco maturity model has a great adaptability to the nursing homes reality. So we introduced very little changes in the survey. Very few changes you can see here on the right side in the text of the survey, and with the only objective to focus the participants' attention in some aspects. As you can see, we introduced some references to the residential care context or the specific tools in Catalonia for e-health or e-social. The most important change was the introduction of the pre-pandemic situation in the individual survey, so we could have a picture of the situation in that moment, a picture of the. By comparing, we could measure the impact of the pandemic on the integrated care in the residential care area. So here on the left, in the green circle, you can see that breadth of ambition is the highest score dimension in both 2020 and 2021. With red circles, you have the dimensions with the lowest scores in 2021, and with blue circles you can see the dimensions that have improved the most their scores from 2020 to 2021. They are the same as the four first dimensions on the graphic on the right side that shows the variation of scores between 2020 and 2021 in each dimension. This big impact on the situation is one of the main findings, and it was a surprise for us not to see an improvement, but the magnitude of the improvement. Here you see how the different profiles score the different dimensions. The lowest scores, the score dimensions are funding and removal of inhibitors, and the highest score dimension is breadth of ambition, You can see also that the most homogeneously scored dimensions are citizen empowerment and innovation management. So this is an example of the graphics that we made for each territorial group. So in the left, you have the evolution between 2020 and 2021. And on the right side, you have the resulting graphic from the consensus session. So you can also see if the consensus made the participants change their mind about one or other dimension. By comparing the 18 territorial groups, so scores are under 3 in most of the dimensions. There are only isolated high scores in funding, population approach, and breadth of ambition. And you can see that more than 75% of the territorial teams agree in their scores on readiness to change, structure and governance, digital infrastructure, and removal of inhibitors. And more than 50% agree in process coordination, funding, population approach, citizen empowerment, and innovation management. And it's important also that there's a high dispersion of scores in breadth of ambition and capacity building. So after the consensus session, it was time for the qualitative analysis of the discussion and the arguments given on the debate. And the main ideas that resulted from this analysis are, for example, that there's a resistance to change because of the fear of nursing homes of being transformed in health centers. That the pandemic has brought some changes, but strategic planning is required. And they also expected some leadership from at the ministry level. In structure and governance, they said that it's necessary to formalize and regulate informal agreements and alliances. Digital infrastructure, the most important thing is that the coexistence of two systems, the health record and the residential care record, so it's necessary to build an interoperability between these two systems. In process coordination, the most important was that the need for new joint protocols beyond the pandemic, because most of the recent health and social care joint protocols are based on the COVID pandemic, but they expected to bring it beyond the pandemic. Here is, you can see one of the important ideas was that a new funding model is required to encourage transformation, and an idea that was repeated in almost all the consensus session was that a better funding scheme should improve labor conditions of the nursing workforce. In removal of inhibitors, the most important was the prioritization of actions should be implemented, and that an integrated care approach should be implemented to remove inhibitors at the ministry level. In population approach, a new stratification modeling and segmentation should be implemented, having as a reference the stratification used usually in the health system. And there's a great potential to aggregate and perform a joint analysis of data from both sectors. In citizen empowerment, they said that a co-creation dynamics should be encouraged. And in evaluation methods, one of the main ideas was that it is required an integrated information scheme to evaluate the integrated care system. In breadth of ambition, and this is important, integrated care now is focused in residential care here in Catalonia, and the participants thought that it should spread to other sectors like home care. Innovation management. The pandemic has contributed with good learning by doing, because the urgence brought to a new collaboration between both departments, but this innovation should be planned and protected in the future. In capacity building, they said that the understanding of social care services in the health sector should be encouraged. So we need to train the health professionals to understand how the social care services work. And in others not related to a specific dimension, but it appeared in almost all the consensus sessions. The participants had an uncertainty about the integrated care real progress after the pandemic scenario. And that's it. Thank you for your attention.
Thank you very much, Felix. Perfect. Again, I would also like you to encourage you to have a look at the chat, as there are a couple of questions for you as well, which we will be picking up during the discussion. And we will move on to our last presentation before our short break. So we will be looking at the concept of goal-oriented care in Flanders. So Pauline and Lotte, over to you.
Does everybody hear me?
Yeah, we can hear you.
Okay, so my name is Lotte and I'm working at Ghent University in the Department of Primary Care and more specifically on the topic of goal-oriented care. Today I'll present to you the adaptation of the Scirocco tool to the Flemish primary care context, and I will also say something more about the integration of the concept of goal-oriented care in the Scirocco tool. But first, I will give you some more context about what has already been done and explain the preliminary trajectory. In February 2021, my colleagues, they gave a presentation about goal-oriented care here for Scirocco, and they already made a connection between goal-oriented care and integrated care. For those who are interested, you have the hyperlink on the presentation to watch it again, because they gave a presentation about existing projects in Flanders, and during this knowledge exchange we saw opportunities to integrate both concepts, because goal-oriented care may be a facilitator for integrated care. The second thing that has already been done is a translation of the Scirocco tool into Dutch. This is a word-for-word translation, but it's abstract to understand because it's a literal translation, and some words they have a different meaning when translated from English to Dutch. And also this translation wasn't adapted to the Flemish context, which makes it very difficult for people to use this Dutch Scirocco tool for care organized in Flanders. And then the third thing that's already existing is that Flanders is divided into 60 primary care zones, with each with their care council. And the Flemish government, they want each primary care zone to make a policy plan for the coming years. And VIVEL, that is the Flemish Institute for Primary Care, they are supporting these primary care zones in making this policy plan. And now VIVEL suggested to use the Scirocco tool for making these policy plans. So this is more about the user expansion that Tino already talked about. And right now there is a pilot project running with 4 primary care zones who are using the Scirocco tool to make these policy plans. But before these primary care zones could use the Scirocco tool, it was necessary to make a new translation of the Dutch tool adapted to the Flemish context. So we started with the original Dutch translation of the tool, and we had different rounds of feedback with different stakeholders, such as the Flemish patient platform, such as VIVEL and the Agency for Care. And the result, after all these rounds of discussion and brainstorm, was that the tool was still too abstract and too difficult to understand, but we saw opportunities for integrated care, and we really wanted to make the tool useful and applicable for Flanders. So that's when we decided to do it different and to make a free translation of the tool. So we organized again a workshop, but instead of using the word-for-word translation, we made an interpretation of all the 12 dimensions. And we asked for everyone who was at the workshop to highlight the most important aspects of the dimension. And an important aspect here was to keep the assessment scale as how they are, as original, because we know that the Scirocco tool is used through whole Europe and even Australia. So it was really important to keep that the same and not change the meaning of a 2 or a 3 or a 4 to make international comparison possible. So this is, I don't think you will get a lot of it, but these are all the 12 dimensions. And for each dimension, we made a word cloud with the most important aspects. And based on all those word clouds, we made a new translation, like a retranslation of the Scirocco tool into a Dutch version that was also applicable for the Flemish care context. And this version is ready, and the 4 primary care zones who are in the pilot project, they are using this version. And as you see, it's like only, so the informative text is changed with also examples from Flanders, but the scores, they are still the same. So this was in brief how we adapted the Scirocco tool to the Flemish context, and we hope in the future that the Scirocco tool can be an input for the policy plans, and that all the 60 primary care zones can use the Scirocco tool to make their policy plans. And then the second thing we also did was to explore the integration of goal-oriented care in the English Scirocco tool. And this is more about topic expansion. So we again had brainstorm sessions with different partners, such as patient representation partners. And in these sessions, we had the feeling that patient engagement was lacking in the tool. Because in goal-oriented care, patients take an active part in the care process and they are partners in this process. And before you can realize goal-oriented care, it's really important to first have patient engagement. And therefore, we want to also broaden the concept of goal-oriented care to the concept of patient engagement, because you first need to have patient engagement before you can have goal-oriented care. And then if we think more about different dimensions in which goal-oriented care or patient engagement has an explicit place, we think about process coordination, because goal-oriented care can inspire the process of care, for healthcare and also for social care, because goal-oriented care is care based on the values and the goals of the patient, and this can guide all the different care plans. And then other dimensions are citizen empowerment, which is one of the main values of goal-oriented care, because citizens are involved as active partners in care. So goal-oriented care or patient engagement can also made explicit in citizen empowerment. And other dimensions are evaluation methods and breadth of ambition. And then in the other 8 dimensions, goal-oriented care can also have a place, but this is more implicit. But this is just like first ideas, and we still need to be further discuss this in detail and to see which adaptations are possible. But we already see great opportunities to integrate the concept of goal-oriented care and even broader patient engagement in the Scirocco tool. But this was, in short, about adaptation of the context and the concept in the Scirocco tool.
Perfect. Thank you very much, Lotte. So these were our 3 presentations on the local experience prior our break. So we are 10:48 now, so we are not running that late. So I would like you now to encourage to grab a bit of coffee. We'll keep the session open so you can keep chatting, keep posting your questions. And we will reconvene back exactly at 11 o'clock. And as I was saying, we will share 2 more local experiences, and then we will open the discussion. So looking forward to seeing you in a few minutes. Thank you for now. Hi, Mattia.
Hey.
Yeah, can you just put it in the presentation mode, the slides? I can see the slide, so it's working well.
You can see it now. I don't know what I have to do. Let me see.
Yeah, it's just on the bottom where you have that, you know, yeah, exactly that thing.
This? Do you see?
Yeah, but it didn't show up for me. Like in the, I see that button down there, but
Let me try.
you see, yeah, exactly that one. That one.
Is it okay?
It still didn't move there. Did you press on?
I'm not sure what is wrong because I see it in the full screen here.
Yeah, maybe you have two screens probably. You have to stop sharing and share again the full screen.
But I don't have two screens. But I'm not so used because I'm on the web. Probably it's because of this. Okay, I will do it again. Window, this one. And now. Is it?
Yeah, and just press that presentation mode on the bottom, on the top. Sorry, top on the down. Yeah, down on that line. Yeah, where you have your, or it's just me.
I did, but maybe I should do it here. I have a full screen. Something happened?
No, it's still like that. Do you want me to share it on my screen?
Maybe
Okay.
it will be better. I'm sorry.
No, don't worry. I'll pop up my slides. So it's 11 o'clock. We are all back from the coffee break. And as I was saying, we are going to share two more experiences from local adaptations, and then we will pick up on the questions from the chat. So we will start with the case from Slovenia, and I'll just open the slides for Matija.
Okay.
Can you see your slide, Matija?
Yes.
Okay, great. Just let me know when to move it for you.
Yep. Okay. Thank you, Andrea, and hello, everybody. So today I would like to share with you the Slovenian experience of using the Scirocco tool. And first of all, I would like to give you just a little bit of background. So long-term care in Slovenia is not integrated into a single system. Andrea, you can move the slide. But is largely divided between the health and social sectors. So at the national level, several attempts have been made over the past 20 years to enact a single law on long-term care. So this is mainly for this reason that we decided to use a Scirocco tool at the local level as part of the Scirocco exchange project. So we wanted to test how it can help improve integrated care from, let's say, bottom up and to realize the potential at the local level without waiting for the national level to take the first steps. So over the last 2 years, we have used the tool on 3 very different occasions and projects. You can move to further slide. And in the first case, we invited some municipalities with worse conditions and less success in home care compared to all other municipalities in Slovenia. Andrea, you can move the slide. And they were all willing to participate, but we were, of course, only able to select one, the first one that applied. In the second case, the plan was to use the Scirocco exchange tool as a communication and planning tool between partners and local actors in 5 projects of integrated care as part of the biggest project, which was testing methods, protocols of integrated care, and where collaboration among all stakeholders is very crucial or essential. And in the last case, we used Scirocco exchange tool in the development of a local strategy in the field of aging. And similar to the previous case, we used the tool as a sort of communication and planning tool to engage all relevant stakeholders and to encourage their collaboration and input into the strategy development process. So let us briefly consider all three cases. First, the municipality of Trbovlje, the first case. Here the assessment process was conducted in October and November 2019. And the online questionnaire was completed by 8 out of 10 invited stakeholders. And then the workshop was attended by 8 people from 6 different organizations. The key messages from these experiences are as follows. You can move the slide, Andrea. The maturity assessment process provided local stakeholders with a more comprehensive insight into the current readiness of the local area for integrated care. And actually the consensus building workshop proved to be a very important step in the whole process. It provided somehow a space for sharing experiences and views and for joint planning of some concrete steps to overcome the existing barriers and to reach, let's say, a higher level of maturity. In a sense, we can say that the consensus building workshop acted like a motivator. On the other hand, the experience in Trbovlje, municipality of Trbovlje, showed that filling in the questionnaire was somewhat of a technical challenge. Some stakeholders needed our technical support, and they also reported that the questionnaire was sometimes challenging and difficult to understand. In another case, the second one, the plan was to conduct the entire assessment process twice. You can move the slide. So at the beginning of the project and at the end. So in July 2020, we, as the evaluator of the project, invited 89 stakeholders from 5 pilot sites to complete the questionnaire, the instrument, and this invitation did not come directly from us, but we helped the project coordinators to do this step. So they were inviting the local stakeholders to fill in the questionnaire. So based on the experience of Trbovlje mentioned before, we also slightly improved the translation and somehow simplified the tool. And unfortunately, the response was low, was quite low. Only 15 stakeholders responded to the invitation. And they also reported technical problems when filling out the survey. And this low response is probably strongly related to the situation of the COVID epidemic at that time, because stakeholders were in a very difficult situation and focused mainly on emergency issues related to the epidemic. But we are still considering implementing the whole process at the end of the project. So we believe or think it could be a useful step for them to see the situation after the intervention and especially to plan their future improvements, which is highly important also because the project will end and they will have to make some changes and further moves. And in the last case, we can move the slide. This is the ongoing project in Domžale. We started the assessment process in this September, and again, we adapted the questionnaire and put more emphasis on the fact that they are assessing the maturity of the local environment. And in this September, 19 stakeholders were invited to fill out the instrument. 13 of them also did it. And we offer different ways to fill in the questionnaire. It was possible to do it online or in Word version or in paper version. And we did our best to recruit them because otherwise the response rate would have been low. And this direct approach was very important. Also, the questionnaire was too challenging for some of them, mainly because they were not familiar with some of the terms, but they were all very willing to participate in the consensus building workshop that was conducted in October, this October. Representatives from 13 different organizations participated in the consensus building workshop. We can move the slide. And the workshop increased their knowledge of the situation by sharing their knowledge with each other. Participants identified key strengths, weaknesses, and opportunities in the transition to more integrated care in their local community, their local environment. And the results of the debate or the outcomes of the workshop, let's say, we will use them in the development of the strategy on aging in a local community. So it is a local strategy. And we should also emphasize that the active engagement of the municipality in the whole process as one of the participating stakeholder and also as the financer of the project plays a very important role and also has a big impact on all other stakeholders' engagement. We can move the slide. So these are three very different experiences in Slovenia with the Scirocco exchange tool. We are experimenting with the different situations, but what they all have in common is that they focus on the local level rather than the national level. And this has proven to be quite a challenge in our case, as the dimensions can depend more or less and also or mainly also on the national level. Thank you.
Thank you very much, Mattia, for these insights into the local level. So we will now move on to our last presentation for the day, and it will be Serena Mignola from Puglia region. Serena, over to you.
Yes. Can you see the slide?
Yeah, if you can. Yeah, perfect.
Yeah, okay. Yes, good morning, everyone. I'm Serena Mingola, and I'm the Scirocco Exchange Project Manager on behalf of the Regional Strategic Agency for Health and Social Affairs of Puglia region, Ares Puglia. And before introducing our first step for the adaptation we are working on with the tool, I'm glad very briefly to introduce what we have already done in Puglia region thanks to the Scirocco Exchange tool, where we assessed in 2020 the integrated care maturity level of our 6 local health authorities. Here you can see our 6 final spider diagrams, and from this data we started a very effective improvement plan, starting from the identification of the dimension that was perceived by the majority of our stakeholders as a weakness of our system. That was the dimension 5 of our maturity model, that is funding. Then we started a participatory process with our local health authority. We selected 6 stakeholders, 1 per local health authority, and with them we co-created a capacity building path with the co-creation of a master in European project planning and management in collaboration with the School of Management of a regional university. This master has a specific focus on health and social domains. So in the improvement plan, we foreseen in the medium term, we hope to create a multi-stakeholder working group in the region coordinated by our agency, and of course to improve process coordination, the quality of project and initiative in integrated care, and the qualification of our human resources. While all these activities are still going on in the region, we also started a knowledge transfer process with the University of Bologna that was since the beginning very interested in knowing more about our tool and our methodology. And with them, in particular with the Department of Biomedical Science, we define a new path of research using the tool to capture the perception of healthcare professionals about the regional response to COVID-19. So with the participants of a master of the Bologna University, that is the Master in Directional Functions and Management of Health Services, we organize an introductory workshop about the tool and the methodology, and then they conducted the individual assessment, and then attended also a workshop that we called in our methodology the consensus workshop on October 13. Participants were doctors, nurses, and managers of the Emilia-Romagna region from different local health authorities and services of the health sector. In this slide, you can see a spider diagram that compares all the individual assessments, and this is a specific function of our tool. While in this other slide, there is the final spider diagram with all the final scores attributed by the stakeholders to each dimension. As you can see, this spider diagram with score from medium to high confirm the services, the high standard of services, the quality of this health system, the Emilia-Romagna regional system that is well known for its quality throughout Europe. Process coordination and population approach were recognized by the participants as strengths of the system. And these two dimensions were linked to different moments of the pandemic. Process coordination was already in place before this crisis, and was supported by very strong and codified pathways. But it was also a guide for all the system during the pandemic, from its start to the lockdown, and also in the vaccination phase. On the other hand, the population approach was a strength, above all in the vaccination phase that is still going on, and above all considering chronic disease and frail people vaccination. The weakness was the readiness to change dimension. It is a dimension where there was a greater difference of opinion among the stakeholders. And also the dimension where in the consensus phase the lowest score was attributed. The COVID pandemic is identified as a disrupted moment in the system where all the criticalities emerged all at once. And for this reason, there is also the feeling of different visibility of all the difficulties linked also with an unprecedented visibility of the health system and its parts. Well, the consensus shows also the differences in the perception and scoring of the health professionals. For example, health professionals working in the back end tend to attribute higher scores than those who work on the front line in contact with people with COVID-19. This difference is to be attributed to information asymmetry from the top down, so little communication, for example, of plans or of programs, but also and above all from the bottom up. So little listening to the condition of those working in the front line. During the consensus, digital infrastructures emerged as a dimension very important for dealing with the emergency. Many stakeholders considered important the use of the electronic health record that was relevant also as a tool for citizen empowerment. The Assembly agreed on the need for a better internal and external communication, and considering the breadth of ambition that is the dimension in the maturity model that measures the integration between level of cares, we observed the fragmentation and discontinuity. We had also many examples of problems experienced by the health professionals, such as problems experienced by women giving birth positive for COVID-19, or above all by elderly in the senior residencies. In my opinion, the most important factor was the sentiment of living a very extended period with no end to lockdowns and now the vaccination phase that emerged strongly. The mental health of health professionals is an issue to be addressed as a priority by policymakers. And last but not least, we registered a high number of I don't know in some dimensions such as capacity building, funding, and evaluation methods that is linked with the poor internal communication that I have already mentioned. Well, for us, once again, the Scirocco Exchange tool represented a powerful tool also to assess and capture the stakeholders' perception of the regional response to COVID-19. As I have said at the beginning, this was the first step of our process of adaptation. So we are going to experiment also in our region with other stakeholders, so our system, this research, and also we are going on with the preparation of a focus group to capture and to listen directly to our stakeholders on how to improve the tool for this specific goal. Thank you.
Perfect. Thank you very much, Serena, for your presentation and all the speakers to sticking to their time. As it looks like we are just on time to start our discussion. So there has been a lot of discussions and questions and observations in the chat. So I will try to pick up a few of them. If I forgot something or misunderstood your question, just please feel free to step in to the discussion. So perhaps I'll start with the questions about difficulties with the adaptation process or the overall experience. There was a question from Diane, and there were also a couple of other observations around that, around resources and time that is needed to do such an adaptation. In particular, this question was for Sandra and the ASL projects, but I think it's a question relevant for other partners who've done the adaptation process as well. But Sandra, do you perhaps want to share your experience? What was, how demanding it was? What were, the main difficulties from your point of view?
Did you say my name or?
Yeah, sorry. Yeah.
I thought I heard Lotte or something. I don't know. Sorry. I was like, it's awfully quiet. So, okay. Yeah, no, I mean, we were, of course, in a way under some kind of a time constraint. And making that that adaptation. But I think again, as I was saying, it was really extremely useful to have people who know the tool and have great experience with it on board to help with that. But it would have been great just to be able to have a little bit more time to really dig into the different dimensions and make sure that they are a little bit more clear also as far as the scaling is concerned, because as I said, there was some difficulty not just in the between the dimensions, but also within the dimensions to really try and have a clear objectives and our scaling for that, and describing of the situation or of where it should go. So and also as a lot of the topics or a lot of the points also related to the language, I think it would be really quite useful to just take the time and break it down into more simple language that a diversity of stakeholders, even the end user on the street, maybe whoever that might be, can really also engage in this dialogue, which I think is just so important to bring everybody on board, right? To see where this is going, where we are right now, and where we need to go with whatever topic that we're dealing with. So, anyway, just some thoughts on that.
Yeah, and there was just one additional question for you while I have you on spot. That do you think that it helped in the process of adaptation and using that adapted version of the tool, that you kind of like know your stakeholders, your group that you've been working with, that they were familiar with each other, that they were not a stranger who came to the room and started doing the assessment?
Yes, of course. It's, as far as the let's say the adaptation process itself is concerned, I think definitely it helped to have a group of people that know each other and know how to work with each other and really, are engaged. But beyond that, also implementing the tool, the adapted tool within the partnership. I think, of course, it's useful to know each other, but I think on the other hand, the tool, in implementing it, I think it's kind of a self. It's something that can be used by anybody, really, and also, let's say, explained how to do it, right? I mean, for that process, I think you don't need to always have, a consortium that is really, quite familiar with each other. But in any case, it always helps, definitely.
Thank you very much. So from your message, obviously you've experienced the difficulties with language, and we've heard that, saw that in the chat as well, that the language still feels a bit kind of like academic and technical. Were there any other difficulties from the other speakers perhaps you would like to highlight from the kind of like, if you look at the adaptation process itself? Is there anything else that we should kind of like concentrate on, take the learning for the future adaptations? I don't, Pauline, Lotte, was there anything else that you spotted? Because you've done, obviously, I think that your expansion, definitely DSL was probably, the biggest in terms of the changes on the content in the questions and the assessment skills. Okay, if not, then I think another question which I picked up from the chat, which was interesting, was from Johanna, and it was to Felix, that she was interested to know, who came with the idea to use the tool for the nursing homes in Catalonia, who take the decisions, and how did you motivate stakeholders to participate in this exercise, or make them actually encourage them to use such a tool?
Mm-hmm. So it was, as I mentioned in my presentation, we were already working together, the health department and the social department, to give our response to the emergency of the pandemic. So in this collaboration, there was two colleagues, Joan Carles Contel and Ana Vila, that heard from this tool. And by the way, thank you, Tino, for your help with this. And to convince the stakeholders and the policymakers, and I have to say that it wasn't difficult at all, because probably because of the situation of the emergency, everybody was disposed to take new opportunities to assess the integrated care in nursing homes. And yeah, that's it. And in the part of the nursing homes, professionals also were suffering the situation, and they were very happy to be asked about their perceptions of how was going on, everything. And so yeah, no problem at all. It was very easy to convince everyone, and we are very happy of the result, of course.
I think that's interesting to hear that for you, COVID-19 was actually a motivation to use the tool. While we hear, for instance, in case of Slovenia, that a lot of the assessment or interest to use the tool or participate in the process has kind of like dropped due to COVID and different priorities on the board. So I think it's interesting to hear that. And while I have you on the spot, there were also two questions around stakeholders you've engaged. So there was a question from Sol from Flanders that you mentioned health and care professionals, and she was asking if you also have any elderly or older people in the group, or it was just professionals themselves.
No, we have just professionals from both sectors, social and health sector. So primary healthcare, social services. Professionals from nursing homes, professionals from hospitals, and also regional authorities from both health and the social sector, but not the elder people, because we thought it was going to be very difficult to include them in this assessment, because you are asking about things like process coordination or digital infrastructure that I think they don't know much about this, and also because of their own characteristics. So you have people with dementia or other illness, and but it's a good idea. Maybe they can be part of another kind of assessment, more focused on their perception about their everyday life or things like that.
Excellent. And I have one last question for you. Like you've mentioned that basically the assessment was done at level those 18 territories. So with the results of the assessments and the maturity process, have you identified any kind of like leading territory, as a result of this assessment?
Yeah, we identified 3 territorial groups that as top scorers in several dimensions. 2 of them are part of the city of Barcelona. So the city of Barcelona was split into territorial groups, and both of them have higher scores related to other territories. The other one is a territory from the center of the Catalonia, the central Catalonia. So,
okay. So it kind of like help you to classify them in some sort of like a maturity. So that's that's interesting. Thank you. Great. I should have picked up that question when we were talking about the adaptation process, but obviously we mentioned the language translations, and there was a question for Lotte from Stuart that if you had if you've documented the process that you've used in your workshop through the doing that free translations. I think it's a good point that we might actually take some learning for a future. So have you done any kind of documentation of that?
Yeah, we made like a planning for it, and we have some documentation, but it's in Dutch, but I can translate it in English and send it to the people who are interested in it.
Mm-hmm. Great, thank you. I think that will be a very valuable resource for us and learning. Great. And then there was a couple of questions about the fact that actually a lot of the experiences or assessments that were presented today were done really at the local level. And we've heard from Mattia how difficult it is then to translate that to national, regional level. And there was a point from Mark, like when you do these assessments at the local level, do they result in the improvement locally only, or is there anything that you can, feedback or improve at the national and regional level? So I don't know, Mattia or Serena, you also have experience with the local assessments. Is it that the improvement is then really kind of like shaped by that local territories, or is this something that links back to the national and regional level?
Yeah, for Slovenia, I can say, yes, there are a lot of improvements for a local level, but of course also for the national level. For the same reason, as we had difficulties to translate it or to adapt it to the local level, because a lot of changes should be done at the national level so they can reflect at the local. So it is in both ways. So yeah, experiences and improvements for the local levels are also important indicator for the improvement in at the national level. And maybe just to say, our stakeholders, they had difficulties to assess the maturity of the local level at quite some dimensions. Let's say the dimension removal of inhibitors. They all see that the biggest removal is the lack of the law that would integrate the both sectors. So yeah, in this sense, it was sometimes hard to assess the scale at the local level.
Mm-hmm. Thank you, Mattia. Pauline, you raised your hand.
Is it better this way?
Yeah, now perfect. Yeah.
So I was in Lotte's team in Flanders, also with Sol, and the balance local, regional, national level was something we debated quite a bit about. And I don't think that's necessarily solved by an adaptation of the tool. I think that when you use the tool in a group of stakeholders, then the tool helps the stakeholders to reflect on when they need to find solutions at a local level and when they need to scale to a higher level. So for instance, in Flanders, the tool will be used by the primary care zones to develop their policy plan. When they will look at the dimensions, I think that sometimes they will decide that they need to solve something or that they need to tackle something in their own region, and that sometimes they will need to talk to other stakeholders at the regional or a national level. The reason why I want to add that is because we tried to translate the tool to the level of the primary care zones, but often the solutions are not there. For instance, a digital health tool, you don't need to develop it at a local level. It needs to be developed at a regional or a national level, because if you develop at a local level, it will be more difficult to scale up. So I think that the tool needs to make the stakeholders think about the dimensions and then debate on whether they need to solve it at their level or whether they need to take the message to another level. And that's something we learned. And I think in Flanders, we will learn more about this when the primary care zones develop their policy plans and really put that on paper, like when they want to solve it at their own level or when they want to scale to another level.
I think this is a great point. Yeah, thank you very much, Pauline. Serena, you wanted to come in?
Yes, I perfectly agreed with this opinion. I would add that we have experimented the flexibility of the tool with our work package 5. So with the analysis we have done in the 9 regions, and we had the national level, the regional level, and the local level. What I would like to stress is the role of the facilitators, because we have seen in this second chance we have using the tool that we did very well. We did better because we have trained ourselves to use the tool. So we were very effective this time to focus on the goal of the research, and also to explain our to the assembly what we expected from the result of the assessment, also how to use the box for the explanation, because it's not enough to answer the question of the questionnaire. We have this very important and powerful tool that is the box to explain why we have done, why we have answered that way in a specific part of our questionnaire. So I think that the tool, of course, can be improved and adapted, but maybe we have also to strengthen the ability to train human resource as facilitators and researchers, that we are researchers. So we know now that with the training we can also help the tool to do its perfect work during the research.
Thank you, Serena. I think that you've kind of like done a nice, I would say, conclusion to the chat, and bringing us to the kind of like a last presentation, which is around the expansion. And you know, those of you who are part of the project, you remember how many times we actually discussed this support that is needed, expertise that is needed, and the importance of the community that has gone through the assessment to actually, I would say, keep us going. Like as you said, you know, training, improving how we are actually using the tool. So I think these are very important elements that, you know, we've heard actually pretty much in every presentation, that there is some sort of support needed, and it's pretty much almost different support in every case. So I think this is really interesting message and finding from today. And I think this brings us very nicely to Mark's and Stuart's presentation on the next steps and, you know, sustainability, exploitation, and all these exciting topics. So Mark, over to you.
Thank you, Andrea. I will now share my screen. Yeah. Voila. Come on. Ah, voilà. Okay. Good. So indeed, so Andrea, you have really introduced the question of what's next and how things will go after the end of the project. So let's go here straight away to the content. So in fact, in terms of exploitation, we need the first thing that we need to do is to materialize the assets that we have, the elements on which we will be able to further work later on. And here with these slides, and Stuart, feel free to intervene. With these slides, we try to say, well, we try to materialize what is already tangible. And what is tangible is, first of all, of course, the tool, also the knowledge hub with this data sharing of knowledge and sharing of evidence that has been developed on the context of integrated care, as well as a number of deliverables and documents and guidelines to develop the tool. But what is important here also is that in terms of an asset, you have seen with the expansion exercise of Axel and of Digital Neighborhood that the tool can be expanded. And here, the idea that we are putting in place now is to have, on one side, one tool with the narratives that on integrated care that we have. And then on the other side, we would have also what we will call the Scirocco framework, which is generic in the sense that it is the machine, the engine that will, and the process of self-assessment and consolidation and consensus building, the processes that, and also the environment that helps to create new a new version of the tool, to adapt or to retranslate a new version of the tool, but starting from an empty environment in order to facilitate the expansion. So that means here that today, in terms of the assets, we have different components, but we have also components which are dedicated to integrated care, or to something that is close to integrated care, and we will also have an environment that is empty, that is generic, and that helps people to communities to develop additional elements. Stuart, if you want to comment on this, or do we simply go to the next slide?
I think that's lovely, Mark. I think we can go on.
Thanks a lot. But an important point that we also really got quite recently, Andrea, is this one: the fact that in the end, to be perhaps a bit blunt, the tool is just a commodity, is an instrument. But what is much more important for exploitation is probably the community, the user community that goes around. So, Andrea, feel free to document or to describe these slides, please.
Yeah, I mean, I think that you sent the main message that for us, running the tool over those couple of years, I think it's become really, intangible. That, as you said, is the community, is the users. All those kind of like facilitators, expertise, human expertise that has been built over those years in using, promoting the tool. So I think we definitely kind of need to think properly what's and how to best use the community, so that the tool and the process, and I would say, the community more importantly is kind of like sustainable beyond the project. So I think it's something, big food for thoughts, but it's just to illustrate that, as we said at the beginning, Tino's presentation, that the community runs from Europe and beyond. So it will be, for us, it's really kind of like a big challenge how to keep it all going, and hopefully by kind of like all that expertise that is already on the ground at the local level, national, regional, that we will be able to kind of like build on it and keep it going. So yeah, I think. Yeah, important message. It's all about the community rather than the tool itself.
And then to make it in a more provocative way also, you are unlikely not to escape from after the end of the project, and we will knock to your doors and invite you to or find a way to keep you engaged in maintaining this community alive. But that's the provocation. Now, going a step, so these are intangible assets these are the assets on which we want to work to ensure that they remain at the end of the project. So the tangible assets, this one, and the intangible assets, this one. So that's really an objective. Now, and I've modified a bit the order of the slides. The point here is that self-assessment or maturity models. This is something that exists. And Tino, please, this is your slide, so please explain us that we are not unique in the world.
Yeah, we are not unique if we broaden the scope of maturity, because there are many maturity models out there, and specifically in the domain of digital health, there is a long tradition of measuring the level of readiness and maturity of digital context. And here you can see some examples, like, for instance, HIMSS has a specific continuity of care maturity model, so it's how digital health is supporting integrated care. The NHS has also digital maturity, so digital in the domain of health service delivery, and there is plenty of them that are measuring this level of digital maturity in the context of healthcare. Which is probably more unique is the evaluation of integrated care, but not from a digital health angle, but from political and managerial and clinical perspective. And this is something that Scirocco is bringing to the market, and I think this is really remarkable because it has these 12 dimensions that can cover much more than digital in this case. So I would reinforce the idea that Scirocco has something unique to bring to the assessment of health systems, which is concentrated on integrated care.
Thank you, Tino. And something unique, and that's a slide that we are starting to work on, so work still in progress, is trying to really formulate what is unique in the landscape with Scirocco Exchange. Integrated care as an element, but also in terms of the tool, what is unique, and in terms of the process, and even in having in mind the Scirocco framework, so the generic version of the tool, what is unique. The idea here is that with this uniqueness, it will be much easier to promote the tool. It will be much easier perhaps to develop a business model that helps to maintain the tool alive and helps to maintain the community alive and all these sort of things. So that's the question that we are having in mind for the moment, and that on which we are working on. And so clearly here, what is unique with the online tool itself is that it is an assessment of the local context, the local environment. That's a unique element. That is also a maturity assessment of an intervention itself that may be unique on integrated care, and also on other, as you see here, the other innovation intervention in healthcare. So that's the way I would frame the market or the area where the tool can be, the generic version of the tool can be used. So in terms of the scope, that's the uniqueness. In terms of the process, there's also a unique element, a series of unique elements here, the multi-stakeholder participatory and facilitation tool, and also this element of baseline tool for co-designing an improvement plan. So these are words. Are they too academic, having in mind the point that have been made? That's kind of things that we need to further develop and further work on. But that's at least elements that we consider as unique. And also then element in terms of providing if we are thinking about the knowledge hub, providing access to available evidence, provided that this available, that the community is feeding this the knowledge hub with evidence, and also we see that the tool can also be used to support knowledge transfer between entities, between organizations. So these are elements that we believe are unique. There are much more, and they certainly can be better better promoted and better defined than this. But that's certainly the element that on which we are working to enable to develop and to promote the use of the tool beyond the community that exists today. And not only to promote it beyond the community, but also to promote it beyond the timeline of the project itself. And that's certainly a key element here. And here you see that in terms of exploitation, we may think about different levels of exploitation. We could of course simply maintain the tool as it is today, no change. We made it publicly accessible. Fine, it's marginal cost. We need just to find an organization we're ready to pay for the license for WordPress, to pay for the license of a different element, and we leave it as it is. Fine, that can work like this. But we can also, of course, if we want to exploit it, we can also, of course, promote, develop training, develop some kind of minimal support. So just to raise awareness about the existence of the tool and the uniqueness and the unique value that the tools is bringing. But then we need a bit more resources for that. More resources will be needed if we want to, and we have, and certainly one of the key lessons that we learn is that new users requires support, but also we have seen that new users, in particular for the framework, so for the generic version, will also need support to design the new narrative, to define the new narratives, to design the new questions, the assessment scales, and so on. So support will be needed to design, to validate the tool, and also support could be needed or could be useful to or consultancy support. So could be useful as an add-on to help to move from an assessment to an improvement plan. So here too, there is an area for developing some business, but depending from the level of resources that can be collected. So as you see here, we can bring value with the tool, more or less. But of course, there is a clear link between the value that we bring and the resources that needed to deliver that. These resources can come from an organization, from different. They can come from different sources, and that's certainly the area we are working today. So certainly, to go from an exploitation plan to something that is running. That is now implemented. We will be working on promoting and doing dissemination on the fact that the project will not that the project will end, but the ambition is to maintain the tool alive and to maintain the community alive. So there's work to be done at that level. We are also the project is also looking for candidates to host the tool and also to provide support. And we need to find not only candidates but also the format of this support that will be provided, and the format for the tool to be provided in a sustainable way, since the ambition here is to continue beyond the end of the project. There will be also a lengthy or a process of ownership and of defining on how to transfer on agreeing on the ownership of the work that has been done so far and how to transfer it. If we are transferring the ownership to a candidate that is hosting, to one or more candidates that are hosting the tool. So this kind of more legal oriented work that needs to be done. And then of course we also need to provide and not only to find candidates to provide some support and to operate the tool, but we will also have to put in place a mechanism to support these new operators, at least for a certain transition period until they are in full control of the process itself. So these are kind of work on which we are working since some months, and that will occupy ourselves for some months. And with this, Andrea, I think that I'm done with this with sketching the next steps. Thank you.
Thank you very much, Mark. So I think that was a nice conclusions or remarks on what's next for us. So as you can see, it's quite a challenging phase on how to keep everything live. So we will definitely be in touch with all of you to keep learning from your experience, from your inputs, particularly on how to further improve the process and your experience with the using of the tool. So first of all, thank you so much to all the speakers for joining us today and sharing your local experiences. It was really invaluable, a lot of new learning for us as the community. And also thank you to all the participants for the live discussions, great questions. And yeah, we really enjoyed the sessions. As it was said a lot today, it's about the community. And I think that Scirocco Exchange community is growing every day. So we are absolutely delighted to have you all on the board. So thank you so much. We will be in touch. As we were saying, we've recorded a session, so we'll do some follow-up very shortly with all of you. Have a nice rest of the day. Thank you very much. Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Bye-bye.
Thank you. Bye.
Thank you so much. Bye-bye.
Bye.